Good morning. Previously, I have told about the history and general survey of the gastrointestinal system. Now, I will tell you the examination of the gastrointestinal system. Now, you should remember that during examination of the gastrointestinal system, after we have taken the history and the general survey, more or less you have understood about the diagnosis of the patient. Examination of the gastrointestinal system, it is actually not very difficult, but as I told you in the history part also, if you make a slightest mistake, you will be penalized, because this is the easiest system, and in undergraduates you are expected to be correct in every step. Particularly in this system, it is applicable to all the systems, but in this system you will have to be absolutely precise and correct. Now, regarding examination of the gastrointestinal system, first you should assure the patient that you are going to examine him. There is nothing to worry. You take him to a room. If there are curtains, it is better. If the patient is female, you should have a female attendant. In a male patient, you should ensure the patient that you are going to examine the patient. There is nothing to worry. You should gain the confidence of the patient. If you don't do that, the patient will not cooperate. So, the first step and the most important step is to ensure the patient that you are going to examine him gently so that he does not get hurt or it cause any harm to him. Regarding the examination of the gastrointestinal tract, you will first examine the upper GI tract. In the upper GI tract, you will see the mouth, oral cavity, gums and the teeth. Now, there are various vitamin B12 deficiencies which lead to the lesions of the tongue, like glossitis. In iron deficiency anemia, there may be some changes in the upper GI tract, and in tonsillitis, the tonsils will be enlarged and congested in bacterial infection or in viral infection. You will see the palate, whether there is any petechial spots in the palate, that will lead to the diagnosis of thrombocytopenia. You will see the teeth, whether there is any dental caries, that indicates patient may have diabetes mellitus. Tongue is also important. In large, if tongue is large, hypothyroidism, amyloidosis may be the cause. In scurvy, there are perifollicular hemorrhages in the gums. So the upper GI tract is equally important. You should not ignore it. You should quickly have a look at the upper GI tract before proceeding to the main lower GI tract. Now, one thing I would want to impress, that GI system examination is never complete without examination of the testes, rectum and anal canal. Probably you will not be able to examine these parts, but you should write that examination of the testes not done, examination of the rectum and anal canal not done, because without these statements your examination is incomplete. These two are very important parts of the GI system. Now, when you are going to examine a particular system, you will first do the inspection, then the palpation. In palpation, there will be superficial palpation, there will be deep palpation, and percussion is also very important, and last is the auscultation. These steps should be followed carefully. Now, when you are examining the patient, আপনাকে একটু দেখছি বাবা, হ্যাঁ, কোনো চিন্তা নেই, ভয় পাবেন না কিছু. Ideally you will expose the patient from xiphisternum to symphysis pubis. I am not doing that because in front of the camera it is not possible to do that. If the patient argues, if the patient does not want to expose, you expose up to this. But tell the examiner that ideally you should be exposed till symphysis pubis. It should be a bit more down. So from xiphisternum to symphysis pubis. Okay. You first see the abdomen. Ideally the abdomen is seen from the bed end. See, the abdomen is swollen and distended. Normally abdomen is elliptical in shape. Here the abdomen is swollen and distended. It is moving up and down with respiration. And see whether there is a scar mark, sinus, fistula, like this. And in this case also we will inspect from the back also to see the back side, whether there are any dilated veins, whether there are any scar marks, fistula, like that. So from the front, from the back and from the sides. You should see the position of the umbilicus. Normally the umbilicus is inverted and it is between midpoint between xiphisternum to symphysis pubis. If there is abdominal distension, here the umbilicus is everted and pushed bit down. So normally the shape of the abdomen, whether it is swollen or not, whether there is any scar mark, sinus, fistula, whether it is moving up and down with respiration, you should see these things. whether there is any surgical mark. So these things go in the inspection, whether there is any mass per abdomen. If there is a big mass, suppose it's a huge splenomegaly, you can sometimes see, but more superficial masses are seen properly. So inspection from the front, from the back. Now we will do the palpation. Palpation is one of the most important parts of the examination. You will ensure the patient that you are going to palpate the abdomen. You ask whether there is any pain. আপনার পেটে কোথাও ব্যথা আছে? পেটে কোনো জায়গায় ব্যথা আছে? If the patient tells that the patient is having pain, don't palpate that side. Suppose if a patient has pain here, you start palpating from the other side. This is known as superficial palpation. Before starting everything, you should rub your hands, particularly in winter months, so that if the cold hands do not make the abdominal muscles to contract. Before starting the examination, you should tell the patient to pass urine. Otherwise, a distended bladder, it may disturb your examination. If possible, passing of stool is also important before doing the examination. So before starting on the examination of the abdominal system, ensure the patient, tell the patient to pass stool and urine, and then start your examination. Inspection, I have already told you. Now palpation, you keep your, after rubbing your hands, keep your palm here and slowly palpate each quadrant of the abdomen. Each quadrant of the abdomen should be palpated gently. This is superficial palpation. Okay. You feel the temperature, you feel the tenderness, whether there is any tenderness, whether there is any mass. See these things in superficial palpation. Now, inspection, palpation. Next part is deep palpation. Deep palpation is the most important part. In deep palpation, you will see the enlarged liver and the enlarged spleen. How you will palpate the liver? Now, this is very important. There are two things. One is palpation of the liver, one is examination of the liver. When you are told to palpate the liver, you should tell the patient, পাটা ভাঁজ করুন, দুটো পা ভাঁজ করুন, দুটো পা ভাঁজ করুন বাবা, এরকম আস্তে করে করুন, কিচ্ছু করবো না, আমি হালকা করে পেটটা টিপবো, পাটা ভাঁজ করুন বাবা, ছেড়ে দিন, পাটা আপনি ঢিলে ছেড়ে দিন, কিচ্ছু করতে হবে না, পাটা ভাঁজ করুন এরকম করে। Tell the patient to flex both his knee joints so the abdominal muscle is relaxed. Now you start your palpation. If you can feel the rectus abdominis muscle, put your hands lateral to it, parallel to the costal margin. Then tell the patient to take deep inspiration. জোরে জোরে নিঃশ্বাস নিন. You can feel the liver edge if it is enlarged. Then you move towards the right costal margin, pressing inwards and upwards. Press inwards and upwards. Press inwards and upwards. Press inwards and upwards till you get the costal margin. As the liver moves down with respiration, inspiration, you can feel the margin of the liver. In palpation of the liver, you will tell where the liver is palpable: side, surface, margin, consistency. Soft liver is round margin. Firm to hard liver, sharp margin. So you have to correlate between the two: side, surface, margin, consistency, movement with respiration. These things are very important in palpation of the liver. Now here, as there is abdominal distension, you sometimes use the dipping method of palpation. Means put your hands, press, then tell the patient to take deep. জোরে শ্বাস নিন, জোরে dip, জোরে শ্বাস. This is the dipping method of palpation of the liver. Now this is the palpation of the liver. You measure the liver along the midclavicular line. It is palpable such and such centimeters from the right costal margin along the midclavicular line. So your measurement should be along the midclavicular line. And I would also want to tell you, this is the palpation of the liver. Now if you are told to examine the liver, you should always look for the liver dullness. For that, you should make the patient sit. উঠে বসুন, উঠে বসুন. Though this is in percussion, I am telling you together because you may be getting confused when you are told to palpate the liver and examine the liver. Palpation, this is okay. But when you are told to examine the liver, you should, along the midclavicular line, you should start percussing. Normally, liver dullness is felt in the fifth intercostal space in the right side along the midclavicular line. So this is the span of the liver. Here, this is dull. Here you are palpating the liver edge. So this is the span of the liver. So this is examination of the liver, and palpation of the liver is just the palpation. So both are different. So try to listen what the examiner is telling you, whether to palpate the liver or to examine the liver. শুয়ে পড়ুন বাবা। And now another important part in the deep palpation is the spleen. Spleen is a very important part. You should remember, when you are getting a splenomegaly, spleen has already enlarged 2 to 4 times. It usually enlarges in the superior and posterior direction. So when it is palpable per abdomen, it has enlarged to a subsequent extent. Same procedure. Ensure the patient, rub your hands, tell him to pass urine. পা দুটো ভাঁজ করুন. This will relax the muscles of the anterior abdominal wall. You should put your fingers near the umbilicus. Some say you can put your fingers in the right iliac fossa. You put your fingers here, put another finger here, this to stabilize it. Then you tell the patient to take deep inspiration. জোরে নিঃশ্বাস নিন. You move diagonally upwards. জোরে নিঃশ্বাস নিন. জোরে, জোরে, জোরে নিঃশ্বাস নিন. জোরে. You will feel the spleen moving down with respiration and hitting your fingers. Spleen, it usually enlarges in this direction, the diagonal direction. When it crosses the umbilicus, it is usually known as huge splenomegaly. Sometimes it gets so huge that you can feel it moving down with respiration. You can feel the spleen. Side surface margin consistency. There is a splenic notch in the anteromedial border of the spleen. This notch is very important, and this will enable you to differentiate spleen from the kidney. And if you percuss over the splenic region, you will get dull. In kidney, it is not dull, it is tympanitic. You will not get, spleen usually sometimes crosses the midline, kidney will not cross the usually midline. But the most specific is the splenic notch. If you can feel the splenic notch in the anteromedial border, this swelling is not an enlarged kidney, but definitely an enlarged spleen. So this is how you see the splenomegaly, this is how you see the hepatomegaly. And now regarding the deep palpation, you will also see the liver and the spleen, and you should try to listen what the examiner is saying regarding the hepatomegaly, whether it is palpate the liver or examine the liver, because very frequently the examination you get confused. So do not confuse, listen to him properly what he or she is asking, the examiner is asking, and then you start your examination. And never forget to ensure the patient what you are trying to do. And another thing is now the percussion. Percussion is, you will percuss the abdomen to feel whether there is any fluid in the abdomen. That is known as shifting dullness. Shifting dullness and fluid thrill are present when there is ascites, that is accumulation of the free fluid in the abdominal cavity. This is known as shifting dullness and fluid thrill, which are used to determine the amount of fluid. For seeing the shifting dullness, you expose, you start percussing along the midline. The site where you get the most tympanitic percussion, you start moving laterally till you get dull. In the point you are getting dull, you move a bit down to ensure that this dullness continues, because sometimes a fecal mass may lead to dull percussion. Here you are getting dull, so give a mark here. You give a mark here. আপনি ওদিকে ঘুরে যান, tell the patient to turn. ঘুরে যান ওদিকে. You wait for 10 to 15 seconds. You wait for 10 to 15 seconds. Then you start again. You see the dullness will shift from this to this. This is known as shifting dullness, because the fluid has shifted, the dullness has also shifted. You always remember, you should repeat the same thing on the other side also. Don't see only one side. Both the sides should be, you similarly do this, move to that side, mark here, region of dullness. Again extend a bit to see this, whether this dullness persists or not. Turn the patient to this side. Again percuss, and the dullness will shift. So there will be 4 lines, here 2 lines, here 2 lines. You can get the shifting dullness on both the sides. Don't see a single side, I want to stress. I am showing one side, but In examination, you will do both the sides. That is very important. And regarding the fluid thrill, it is very easy to tell the patient, আপনি হাতটা এরকম করে রাখুন এখানে, ওই হাতটা দেখি দিন, ওই হাতটা দিন, এখানে রাখুন, এরকমভাবে রাখুন, ছেড়ে দিন, ওই হাতটা এই হাতটা ছাড়ুন, হ্যাঁ এরকম রাখুন হাতটা, এরকম করে বাবা, এরকম করে, হ্যাঁ এইরকম এইরকম, ওরকম না বাবা, ওইরকম না, ওইরকম না, দেখি, হ্যাঁ এইরকম এইরকম, এই হাত দিয়ে করুন, হচ্ছে না ঠিক, যাই হোক এরকমভাবে রাখুন, ঠিক আছে? Here you press, give a mark here. Here you press, give a mark here. So this is the fluid thrill. Fluid thrill is usually present if the amount of fluid in the abdomen is more and it is less, you will not get the fluid thrill. So shifting dullness and fluid thrill are very important. And another thing which is very important in inspection is the dilated veins on the abdominal wall. You should always look for dilated veins on the abdominal wall in the inspection of the abdomen. It is a very important thing. You should see the direction of movement of the veins, how it is feeling. I will not be able to show you here. If it feels away from the umbilicus, it is usually due to portal hypertension. In superior vena cava obstruction, blood will move towards the venous blood will move in this downward direction. Inferior vena cava obstruction, just the reverse direction. So in inspection, the dilated veins is also very important, and you should also inspect the back for the back veins. So inspection, palpation, percussion. Now the auscultation. Auscultation we very often ignore, but it is also very important. You put your stethoscope here in the umbilical region and wait for some time. You see gurgling sound moving every 5 to 10 seconds. This is the intestinal peristaltic sounds. It will be a gurgling sound, not like a heartbeat, but a gurgling sound moving around like this. This is the peristaltic sounds. It may be hyperperistalsis will be there, it will be more frequent, it will be quicker, peristalsis may be slow, so the sounds will appear at larger intervals. It may appear at quicker intervals, it may appear at larger intervals. So the peristaltic sounds is very important. You should palpate, you should also auscultate for the renal bruit. It is patient in young hypertensives, renal bruit. You put your stethoscope here and listen for the bruit. It is not heard very commonly. Particularly, you should look for this in hypertension in young patients. This is inspection, palpation, percussion, and auscultation. This entire examination you will have to complete within 10 to 15 minutes maximum, because the time you are getting, you will not get too much of time. You will have to be quick and precise during the examination procedure. Now, after the inspection, palpation, percussion, and auscultation is over, you should try to investigate. How will you investigate this patient? See, a patient having ascites. Ascites usually occurs due to accumulation of the free fluid in the abdominal wall. It may be a transudative ascites, this is ascites with low protein, exudative ascites, ascites with high protein. Now it is replaced with low sag ascites, high sag ascites. Sag means serum ascites albumin gradient. It is the albumin gradient between the serum and the ascitic fluid. So if the ascitic fluid has got low albumin, so sag will be high. Just is the reverse in the reverse case. So ascites occurs in heart failure. Ascites may occur in portal hypertension. Ascites may occur in nephrotic syndrome. These are some of the causes. Sometimes in exudative ascites, there may malignancy may be a cause, abdominal malignancy may be a cause of exudative ascites. Metastasis to the abdomen may cause an exudative ascites. In India, the most important cause is tuberculous peritonitis, when you will get ascites with pain abdomen. In a case of ascites with pain abdomen, think of two diagnoses. First is tuberculous peritonitis. If the ascitic fluid is exudative, it will be a tuberculous peritonitis. If it is transudative, means if the ascitic fluid albumin is low, think of a portal hypertension. Other causes are there, but these two are the primary things which you should suspect. Now, you should do the complete blood count to see whether the patient is having anemia. In case of portal hypertension, there will be bleeding esophageal varices, so anemia will be microcytic hypochromic anemia. In malabsorption syndrome, vitamin B12 folic acid deficiency, there may be MCV will be high, that is mean corpuscular volume. Mean corpuscular volume will be high in vitamin B12 folic acid deficiency. Anemia, it may occur due to bleeding varices in the form of hematemesis, melena, like this. And in vitamin B12 folic acid deficiency, there will be anemia also. There will be symptoms of malabsorption, there will be pedal edema, there will be recurrent history of loose motions, but MCV will be high. Now, regarding fasting sugar urea creatinine in patients presenting with chronic liver disease, there will be hypoglycemia. The patient will give history of sudden attacks of dizziness due to decrease in blood glucose levels. Urea creatinine, if it is raised in case of ascites patients of chronic liver disease, then we will think of a hepatorenal syndrome. I will not going into details because it's a very difficult part for you undergraduates. Next is the liver function test. It is very important to see the bilirubin level, whether it is a conjugated hyperbilirubinemia or it is an unconjugated hyperbilirubinemia. If the patient is having unconjugated hyperbilirubinemia with anemia and there is splenomegaly, think of hemolytic anemia. But in case of conjugated hyperbilirubinemia with the rising of the liver enzymes, reversal of the albumin globulin ratio, ALT will be more than that of AST. You always think of a chronic liver disease due to viral hepatitis. Alcoholic hepatitis, AST will be more than ALT. So these enzymes are very important. In cholestasis, GGT will be raised, this gamma glutaryl transpeptidase, and alkaline phosphatase will also be raised. These alkaline phosphatase and GGT will also be raised in cholestatic jaundice. There will be itching in cholestatic jaundice. There will be loose frothy stools due to malabsorption. And there may prothrombin time may also be raised due to the deficiency of vitamin K in malabsorption syndromes. Now we will do a chest X-ray to see whether there is associated, because tuberculosis is often present with chronic liver disease because these are immunosuppressed persons. Diabetic patients are often susceptible to chronic liver disease. It is known as NASH, non-alcoholic steatohepatitis. And regarding the sodium potassium, there may be dilutional hyponatremia, means sodium may be low but the patient is conscious. This occurs in ascites patients due to dilutional hyponatremia. Then you restrict the salt. And regarding echocardiography you should do, because sometimes constrictive pericarditis presents with features of chronic liver disease. So echocardiography is also important. Electrolytes are also important. Next is the ultrasonography whole abdomen. This is the most important part of the examination. In the case of patient of chronic liver disease due to portal hypertension, you will get enlarged spleen. This is known as splenomegaly. And you will get diameter of the portal veins will be increased and the hepatic echo texture will be coarse, will be nodular. So these things will enable you to diagnose a chronic liver disease. Next, there are other investigations also, but I will not go into the details of that. Next is the treatment. You will treat according to the cause. In case of tubercular peritonitis, you will give antituberculous chemotherapies. In case of chronic liver disease, you restrict the fluid intake if there is hyponatremia, you restrict the salt intake. You give the patient diuretics in the form of Lasix, means furosemide and aldactone, or the combination of both you can also give, that is furosemide with aldactone. You may avoid aldactone and give eplerenone, but the only difference between the two is the side effects of aldactone are not present when you give the eplerenone. Otherwise, efficacy of both are similar. And you also try to see whether the patient presents to you of chronic liver disease patient may present to you with shock, with hypotension, tachycardia, hematemesis, that is vomiting of blood, melena. This is a medical emergency. Immediately you would do an endoscopy and see whether the patient is having varices. You treat the patient by endoscopic sclerotherapy or band ligation. Now, this is how you overall examine a case. You first take the history, you take a general survey, and then do for the systemic examination, then the investigations and the management. I hope this will be a little bit of help to you, though coming to the wards and seeing patients by yourself is of tremendous benefit, but in this period of COVID pandemic, we have no options. So I hope whatever I have taught you today, you can understand clearly. Thank you.